Okay, should we start?
Yes, you can start now.
Okay, good afternoon, everyone. It's a pleasure to be in your company this afternoon from all of us at the Ethiopia team, as well as from the Ethiopian Medical Association. Welcome to our first webinar. As you know, Ethiopia has been promoting evidence-based medical education, as well as the dissemination of information to the data to the public at large, right from the onset of the COVID pandemic. By chance, that's when the initiative was started online. And today we'll be launching our continuous medical education arm of the Ethiopia platform in collaboration with the Ethiopian Medical Association. We hope to deliver one continuous medical education session per month, but the first two CME sessions will be delivered with 2 weeks apart. Before I start the webinar proper, I invite Dr. Bezavit from the Ethiopian Medical Association to say a few words on our collaboration, and I will proceed with the discussion in a few minutes. Thank you very much. Dr. Bezavit?
Good morning and good afternoon, everyone. Can you hear me?
Yes.
Okay, great. So my name is Bezavit Alemayehu. I work at Ethiopia Medical Association as a project manager for the Health Workforce Improvement Program. Continuous professional development is one of the major pillars of Ethiopia Medical Association, which is why we have started collaborating with the INAWEG for this programs where we deliver CME sessions. And at the end of the session, you will be receiving a certificate containing 1 CEU unit. Thank you for joining us. Back to you, Dr. Tinsae. Dr. Tinsae?
Okay. Thank you, Dr. Bezavit.
Thank you.
So my name is Tinsae. I'm a pediatric ID specialist. Thank you very much.
There may be a problem on the connection from Ethiopia. I have a pre-recorded lecture from Dr. Tinsae about the same topic. We can run that while the connection and everything gets back. If that's okay with the attendees, please let me know. But I can run the pre-recorded session.
Thank you, Dr. Fusum. I think that's a great idea considering the network problems here in Ethiopia, and we want our participants to receive the best, knowledge. So please proceed. Thank you.
Okay. Yeah, I'll do that. Just give me a second.
Hello.
Okay.
everyone, welcome to the first continuous medical education platform that has been organized by the Ethiopian Medical Association jointly with Anticoagulants medical education platform. The first session is concerning the management of children with COVID-19 infection. My name is Tinsae. I'm a pediatric IT specialist for Exact American Teaching Hospital. As of the 20th of May 2021, more than 5,200 children have been diagnosed with COVID-19 in Ethiopia. First child who was reported to have this infection was diagnosed on March 29, 2020. That was a 14-year-old male. And also very young age, that diagnosis age is less than 3 months. Thankfully, low income or poverty has not been shown to be associated with the diagnosis of severe COVID in children. The latest taxonomy of the SARS-CoV-2 virus shows that it belongs to the coronavirus as well as the genus Beta-coronavirus. And based on experience from our center, the majority of symptomatic children present with fever and cough closely followed by a runny nose. Of course, there is a significant proportion of children who present without symptoms and who are tested simply because the pandemic has tested. Identify the pathology, underlying pathology, and this is best exhibited by lessons which are extracted from autopsies of children who have died due to COVID-19. So the predominant features when autopsies are examined of children with COVID-related disease is the first is the presence of intense inflammation as shown by alveolar damage, formation of Alemayehu, as well as vasculitis in different organs of the body. Thrombotic events, fibrin thrombi are exhibited in the brain, heart, lungs, etc. And also, so at least with COVID-19, we tend to show more external info. During the phase 1 of illness, there is intense viral immunity and antivirals such as remdesivir can be given, managing the intense inflammation as well as providing anticoagulants that's shown by the autopsy reports that exhibit the presence of venous thrombosis in parts of the targets reduction of inflammation such as JAK inhibitors and monoclonal antibodies. The best studied antiviral for COVID is remdesivir, as an RNA polymerase inhibitor, thereby the maximum benefit from this drug, then it should be started early on during the disease, less than 10 days from the onset of symptoms. It's not a completely new drug. Medical literature is aware of the benefits of remdesivir, at least for the past 2 decades. The management of Ebola virus disease, the original SARS-CoV pandemic, Middle Eastern respiratory syndrome, as well as common human coronavirus causes of common cold. The current recommendations on the use of remdesivir rely on 3 landmark trials. The first, performed by Baker and colleagues, was a multi-center randomized control trial comparing 10 days of remdesivir with the standard of care. More than 1,000 hospitalized adults, and hospital stay was shown to have been shortened by 5 days. The second, the simple severe trial, was again a large randomized control trial which compared 5 days of IV remdesivir with 10 days of remdesivir in close to 400 hospitalized adults who were not requiring mechanical ventilation. And the 2 arms showed comparable clinical status at the end of 2 weeks. The simple moderate trial tried to see whether IV remdesivir had benefits in the first arm, with 5 days of treatment. The second arm was 10 days of treatment, and in the third arm was a standard of care. This was performed on close to 600 patients, and in particular relevance to the topic that we are discussing today, the protocol changed midway to include adolescents aged 12 to 18 years old. The outcome showed that 5 days of remdesivir had the best containing than the other 2 groups. Of course, the findings of these 3 trials are counteracted by the WHO Solidarity trial, which was a single trial showing that remdesivir had little benefits in terms of mortality as well as morbidity. Concerning pediatric data on the use of remdesivir, the majority of evidence exists in the form of case reports as well as case series. The youngest patient to be successfully treated was a neonate aged 19 years of age. But countries with the largest pandemic, such as Spain, have shown successful treatment in immunocompromised children, such as those that have oncologic malignancies. Recently published case series of 77 hospitalized children from the United States showed that administering remdesivir was associated with increased oxygen need as well as earlier extubation as well as mortality benefits. Recommendations for children weighing 3.5 kgs and above. The duration is for 5 days in severe cases, and 10 days for critical illness. You have to be cautious. You have to take note of adverse reactions such as worsening of in remdesivir infusions, hypersensitivity reactions more often seen when the infusions are rapidly given, and also transient transaminitis, which is the commonest adverse event that is seen in association with clinical application of remdesivir. So lab monitoring, especially liver function tests before and during treatment, is mandatory. Experience with remdesivir at our center over the past 3 months, when we tried to assess about 26 patients who received remdesivir, only 1 patient had increasing liver enzymes compared to baseline. But even that patient did not require discontinuation of treatment. Majority had normal liver enzymes prior to treatment, during treatment, and post-treatment, or had slightly elevated liver enzymes at the start of treatment, probably due to transaminitis. Moving on to the management of the intense inflammation. Tocilizumab is an interleukin-6 inhibitor. It's a very expensive drug administered parenterally. In children, it's approved for the management of acute graft-versus-host disease, as well as a host of rheumatology conditions. The reason being for administration of this drug is because of increased interleukin 6 and C-reactive protein are associated with poor outcomes because they promote cellular immunity differentiation, CD4 and CD8 differentiation, as well as antibody production. If you are going to benefit from this drug, then the patient should very early, less than 24 hours after patients with a rapidly progressive type of disease, or when criteria for COVID-19 cytokines or rate very early on. The evidence for large adults. In hospitalized adults, we have started with 48 hours. The available evidence is for children with anti-inflammatory syndrome associated with COVID, and we are waiting for the latest data from specifically two tracks, the COVID-19 and the recovery of 2021, or at the start of 2022. The main administration. There is no consensus on giving antifungal or antibiotic prophylaxis after giving tocilizumab, but at least you have to avoid live viral vaccines. So this drug is given at a single dose, and if you do not witness adequate clinical improvement, you can repeat the second dose in about 8 to 12 hours. Relative to the other drugs, steroids are data study. And this study population of more than 2,000 patients who receive oxygen, whether they are ventilated or not. Even though the majority of evidence exists for the there are smaller trials to show significant benefits. One as well as 5 days of treatment. But still large sets of pediatric data pending. As we have already discussed, the third arm of management depends on effects of metabolic events. Most of the current recommendations have relied on 2 studies performed on mechanically ventilated adults very early on during the diagnosis of severe COVID, and administering anticoagulants were associated with less number of days in the hospital, more ventilated-free days, as well as less mortality. But there are still ongoing trials in inpatient as well as outpatients trying to assess the efficacy of oral anticoagulants, heparin, aspirin, and other agents also. There's limited pediatric data that suggests that starting anticoagulants in children with severe COVID is associated with decreased mortality, especially when they have anti-inflammatory syndrome associated with COVID-19. There are small cohorts reported from the United States that have shown that the incidence of venous thromboembolic events is especially high in ages above 12 years of age or adolescents. Whether a child has COVID or not is either risk of operation. When there is personal history of venous thromboembolic or a family history, as well as when there is immobilization due to various obesity or recent surgery, etc. When there is congenital or acquired disease, as well as dyslipidemia, then we have been practicing prophylactic anticoagulants for such children, and it's not a novel concept to pediatrics following on. So we have to screen all children upon admission prophylactic administration, we have to use enoxaparin or unfractionated heparin because of more extensive again, for large scale for example, the coma efficacy of prophylaxis in children with severe COVID pathologies. We are waiting for such large-scale data to make a general recommendation. There are non-pharmacologic options for venous thromboembolism prophylaxis, such as early mobilization of patients, hydration, mechanical prophylaxis, such as applying anti-embolism stockings, etc., are not specific to strong pediatric data, even though sizes are available for adolescents. So these three options can be used as a non-pharmacologic measure for prophylaxis. So since the highest thromboembolic risk is associated with adolescents, because of older than 12 years of age with no known contraindication, then prophylactic anticoagulants are recommended. For children younger than 12 years of age, then a case-by-case assessment and risk stratification should be made before deciding to administer these drugs. These are experimental anti-inflammatory therapies that really do not have sufficient data for using children, such as JK inhibitors, baricitinib, which is an orally administered drug, monoclonal antibodies, and also convalescent plasma. Regarding convalescent plasma, there have been no benefits in reducing mortality or hospital stay in association with administering this therapy. There are also issues of its dose being not properly defined. There are few pediatric case reports, and we are awaiting for the outcomes of 3 pediatric trials concerning the use of convalescent plasma in severe COVID-19. A unique syndrome in severe COVID-19 is the multi-inflammatory syndrome associated with COVID. Just first reported in March 2020, and it usually appears on a final phase of COVID-19 infection, period in which there is less viremia and there is intense inflammation. And its postulated mechanism is it being associated with excess cytokine storm after the viremic phase. Apologies for background noises. WHO defines multi-inflammatory syndrome associated with COVID as a patient aged less than 19 years who has fever of more than 3 days, plus 2 or more of the following: dermatologic, myocardial, coagulopathy, gastrointestinal manifestations, or shock. So if there are at least 2 or more of the following signs in a febrile child less than 19 years of age with elevated markers of inflammation and evidence of COVID-19, are more likely to be extracted from positive serologies, because by this time the positive PCR or antigen test, then you can define MISC. We reported the first case 2 months ago in child who fulfilled our criteria in the absence of an alternate diagnosis. So one of the possible manifestations of MISC is Kawasaki disease-like manifestation. Symptoms can be very mild and have Kawasaki disease-like manifestations, or can be associated with shock. So it's good to, especially for practitioners in Ethiopia, to familiarize ourselves with the manifestations of Kawasaki, which is fever of 5 days duration, presence of non-virulent conjunctivitis, sparing the limbus, presence of cracked lips, strawberry tongue, palmar or sole erythema, as well as cervical lymphadenopathy and exfoliation of the area of the skin once the disease nears resolution. There is no specific dermatologic manifestation associated with multi-inflammatory syndromes. COVID can have erythematous, papules, macules, all sorts of manifestations. This is also shown in experience. These are some of our patients with MIXC. You can see front can be formed, extremities can be formed. It can be a complaint.
Let me see. I need a band.
For acute COVID-19, activity evidence of benefits. Based on evidence of benefits from the recovery trial, we can also any case of in order to have decreased mortality. And also based on some evidence of clinical benefit in adults, especially when children are 12 years and above. Prophylactic anticoagulants are also important concept. The very strong way for risk severe COVID. In those children with cytokine storm, with multi-inflammatory syndrome associated with COVID, then that's where we can get maximum benefit of this. So there are many drugs which are being tried. So the coming months will definitely add to our knowledge of managing severe COVID. SARS-CoV-2 can throw up mutations, point mutations, insertions, and deletions, which can affect the function of the spike protein and also have more clinical outcomes due to high viral loads. The main variants of concern are 5, the UK, South African, California, Brazilian, Japan strain, as well as the Indian strain. Most of them share mutations with one or other difference in deletion or insertion amongst themselves. The most common variant of concern currently globally is the B117 strain or the UK strain. Regarding COVID vaccines for children, so far only the RNA vaccines have trialed in adolescents and have shown benefits. Moderna and Pfizer have been approved for ages 12 to 18 years based on their clinical trials in this age group. While we are waiting for trials for younger children, all the other groups of vaccine, the adenovirus vaccine, protein-based vaccines, and inactivated vaccines are yet to conduct pediatric trials. Thank you very much for your attention and apologies for the occasional disruption of noise. I would like to open the floor for questions and comments. Thank you.
All right, thank you, Dr. Tinsae. That was an excellent speech. I apologize for all the attendance in this webinar today for the poor sound quality and for occasional interruption. But what we will do is we have the pre-recorded video in a better sound format. We're going to post it in our Telegram group that we created for physicians and medical students. So anytime you can go back and watch the whole video again. It's also uploaded to our YouTube channel. But for a better quality, we'll just upload the video to the Telegram group that you can join anytime. So now the floor is open for question and answer. Anyone in the attendance group, if you show me or you raise your hand, we can, lift you up to ask questions, anything related to the current topic about COVID and pediatrics, particularly in Ethiopia and what we discussed today. You're welcome. Dr. Tinsae, if you want to add, I know some of the points were missed, so if you want to say some things while they raise questions, we can do that.
Okay, thank you. Am I audible?
Yes, I can hear you.
Yeah. So apologies for our audience. So the main points are this is a rapidly shifting part of clinical care. So for all recommendations that we are discussing today are just based on the things that we know currently. Now we expect more data on the use of remdesivir in children, as well as better outcomes from the trials currently being conducted on the use of anticoagulants, especially in children younger than 12 years of age. With regards to vaccines to be used in children, we only have data on the RNA vaccines. All of the other 3 groups of vaccines are yet to conduct pediatric trials. And also I want to stress to be on the lookout for cases of multi-inflammatory syndrome associated with COVID, especially after the viremic phase is over, which can present as discussed in a Kawasaki disease-like manifestations and who have positive antibodies. Thank you.
While the attendees are waiting, I know we have started giving vaccinations to younger adults, like kids between 12 to 16 years of age. They are getting the vaccine. Is there any hope, or is there anything planned about giving vaccinations in Ethiopia for children, or is there a discussion, among pediatric society or Ministry of Health regarding that topic?
We are yet to reach the stage at which we can vaccinate younger adults as well as children, because at-risk health workers as well as older individuals with or without comorbidities are yet to receive the second dose of the AstraZeneca vaccine, which was administered about 6 to 8 weeks ago. So I think we haven't yet reached that stage.
Anyone from the audience, if you have seen pediatric age group patients with COVID or anything related to that area, Dr. Tinsae would be the right person to ask. Or you can ask anything related with, COVID and children. Would be a good opportunity to have this case-based discussions. Also, we have this continuous platform, like I mentioned earlier. There's a Telegram group. If you see some challenging cases or interesting cases, you can post your questions anytime. Someone might be able to answer you, what will be the management, what, steps you need to do the diagnosis, or if there are any related research papers around that topic, that would be a good resource for you to use. I'll share you the link here. And also, if you don't want to miss if you don't want to miss, upcoming events, you can, always follow on the group, because I think we'll have in 2 weeks' time, we'll have a very good discussion about viral hepatitis by one of renowned hepatologists from Ethiopia. We'll try to make sure that there's no sound quality problem at that time. But I'll wait another 5 to 10 minutes for the participants. If you have any questions, you can raise your hand. I'll let you be able to speak and ask the presenter.
Just to add on the vaccine part. So in our country, it's not common to have early marriage, as well as the age at which the first pregnancy occurs is relatively younger than what we see in North America, Europe, or the rest of the world. So even though the current mRNA vaccines such as Pfizer and Moderna are producing encouraging results with regards to vaccinating 12 to 18-year-old adolescents, they are yet to include pregnant adolescents. So just to stress on that point. Thank you.
Dr. Bezavit, if you have anything we can add, and I think we can, if there's no more questions, we can wrap up our first CME soon.
Thank you, Dr. Fuzul. I would like to add on, I would like to ask Dr. Tinsae to elaborate more on the medication, such as toxinizumab and rivaroxaban, how these medications are now, whether they are recommended or not recommended, as well as anticoagulant therapy in children with COVID, as well as infectious diseases such as HIV and their outcome related to childhood COVID. Thank you.
So thank you for the question. The very few experience with tocilizumab in COVID-19 is associated with children with multi-inflammatory syndrome with COVID. There are very few pediatric trials on the use of this drug for decreasing inflammation. It's also a very immune suppressant drug. There are good trials, about 6 or 7 in adults, especially those who are mechanically ventilated, as well as who are early on in the clinical course after confirmation of severe disease, that tocilizumab has been shown to decrease mortality. It's also a very expensive drug. We should not forget that. So at present, unless the child has a multi-inflammatory syndrome associated with COVID, then it would be really difficult to use this drug in children with severe COVID-19. Regarding anticoagulants, so especially if a child is above 12 years of age and has no contraindications to receive low molecular weight heparin, then these are the type of children, especially 12 to 18 years of age, that can really benefit from prophylactic anticoagulants. Again, pediatric trials with the use of enoxaparin for severe COVID are going on. For children younger than 12 years of age, unless they have a clear-cut risk factor, which I have tried to touch upon in the discussion, such as a background congenital or acquired heart disease, or a family history of venous thromboembolic events, or a personal history of venous thromboembolic events, then at least we can monitor closely their coagulation profile and clinical symptoms before deciding on anticoagulants. Vitamin C is not associated with any benefit or harm for COVID-19. This was also one of the questions that was asked in our chat box. So none of the vitamins have been shown to have clinical benefits in any of the trials involved with COVID-19 treatment, as well as GI prophylaxis with PPI. One of our attendees, Dr. Mubarak, has asked whether we can get this PowerPoint for further use to be shared among all attendees. Yes, that's possible. Thank you very much.
We will share you this, I think, both on EMA platform, Ethiopian Medical Association platforms on social media, on Facebook, or on their email. They will have this video, the pre-recorded one, and also we'll also upload it in our different platforms, including Telegram, so you can access this video anytime. For those of you who attended today, as we said earlier, attending a CME will give you 1 continuous educational unit credit, 1 CEU credit. But for us to verify and be able to send you this educational unit credit, please send me your name and email. I'm writing here to the email you need to send it. It's cme.yetenawag@gmail.com. I'm typing it below at the bottom of our chat. So please make a note of that. Just send us your name, your position, and your email to cme.yetenawag@gmail.com so that you can get the appropriate educational unit credit from EMA. Is that how we do it, Beza? Or there's something we need to do more?
Yes, possible. They can also type their name, email addresses right here in the chat box, and we will take a note of that, and we will send them the certificates. And we like to apologize for the network issues. We will improve those for the next session. Thank you.
Yeah, you have to send the name and the email, not on the chat box, because the chat box will disappear once we close the webinar. Send it to the email I wrote there, cme.yetenawag@gmail.com, and we'll share that with Emma, and then they we'll have your name. We'll also have taken the name of the people who are in the attendees, so we'll know who's attending here. But just make sure that you send your name and email. I don't know if Dr. Tinsae answered it. I have some questions from Dr. Mubarak. Were you able to see it on the? Dr. Tinsae?
Yes, yes, I was able to see it, and I've tried to incorporate the answers along with my answers to Dr. Bedford. There's also another question on the chat box asking whether tocilizumab is available in Ethiopia and also the price. It is available. The price is very expensive, varies a lot. So in the very few patients that I have seen it used, a single dose is costs about 1,000 USD.
Okay. All right. If there are no additional points, all participants, we really appreciate for you coming to our first CME session that we created with Ethiopian Medical Association. We are very thankful for Ethiopian Medical Association for being with us, supporting this platform, and encouraging us to do lots of things. So I am very encouraged in what's the management and the leadership in Ethiopian Medical Association. They are very very open, and they like to see new ideas, and I hope most of you are able to engage and participate with lots different types of Ethiopian Medical Association initiatives. From what I see, there's a lot of engagement, and they have come a lot of way to come and engage with us, and I hope this partnership will continue in the future as well. So this CME program will have at least once a month. We'll bring and discuss a very important topic. Our next session, we'll announce it soon, but it will be about viral hepatitis with one of our prominent hepatologists, Dr. Amir from Ethiopia. We'll try to make sure there's no sound issues or this kind of issues next time. And I think make sure that you send your email to cme.yetenawag@gmail.com so that you can get the credit. You spend your Saturday watching this lecture. It's helpful, but also we want you to get the credit for taking your time to participate here. So we'll send you soon. It may take a week or two until we process all the necessary forms and everything, but we'll make sure we send you a certificate for that. And I think I'm told that is necessary for license renewal at this time, so it's good.
Okay, so maybe we can answer one more question from the live Q&A.
Yes.
Yeah. So one of our attendees is asking which clinical sequelae can be seen after severe and critical COVID in children. So this remains to be seen, of course, during the course of the follow-up. I'd like to take note of two things that I have seen with increased incidence in children with COVID-19 that I have treated. So the first one is, as I've already mentioned, the MIAC. The MIAC syndrome is the number of cases that we are seeing is increasing by the month. Along with the recording of this session, we will share case reports of Ethiopian children with this syndrome so that it can serve as a comparison for any of the cases that you see. The other thing that I am yet to explain is that we are seeing a lot of new diagnoses of diabetes mellitus as well as DKA in children with severe COVID-19. I don't know whether this is due to direct pancreatic inflammation due to the virus itself, but that's one unique thing that we are seeing with increased frequency.
Thank you. Any more questions? You answered the tocilizumab question, right?
Yeah. So another question is when we should give tocilizumab and whether we can give prophylaxis or not. So there is no consensus on whether to give antifungal prophylaxis with itraconazole or antibiotic prophylaxis with cotrimoxazole after tocilizumab administration in COVID-19. One thing is for sure, in the few weeks that after you give tocilizumab for these patients, there is severe immunosuppression, which is one of the adverse reactions of this drug. Maybe those of you who are practicing in the US, maybe Fizze or any other attendees can comment on this. What antifungal or antibiotic prophylaxis have you given after tocilizumab, whether it's for COVID or for any other illness? Thank you.
With certain monoclonal antibodies, I'm not sure with tocilizumab. I'm not familiar. I haven't used it in COVID. But using antifungal and antimicrobial prophylaxis is not common, and it's not what you see here.
I see no more questions in the Q&A section as well as in the chat box.
Again, some people are still asking me about the email. You can send it at cme.yetenawag@gmail.com. I'm typing it at the chat box again. I think I've typed it 4 or 5 times. I don't know, it may not be showing up. It's cme.yetenawag@gmail.com. We are not the one who'll be processing it. It will be through Ethiopian Medical Association because there's standard where it has to be processed, but we have the name of the people who attended today, and we'll share it with Emma. Dr. Bezait from Emma is here. So we'll get a certificate of CU credit for attending this lecture. Our next lecture will be, we'll announce it soon. Stay tuned. If no more questions, I'll like to thank Dr. Tinsae Alemayehu, who is an expert on his field, who has done pediatrics, infectious disease subspecialty, for coming here, giving us your time from Saturday. I know you have a busy clinic, lots of patients, and also you're doing lots of research and papers, and I know how valuable your time is. And I'd like to thank our attendings who attended our webinar, And thank you, Dr. Beza. Again, you have been very helpful in lots of different platforms and organizing different things with us. So Emma and Dr. Beza, very thankful. So we'll meet again in the next webinar. We'll announce the date. Stay tuned. Thank you again. Have a beautiful Saturday.
Thank you, everyone.
Thank you, everyone.